slide over here, where you can see how the NAFLD have worked itself. Let me explain you how it works. Sorry, it's not working. I don't know why. Yes. Every single step of fibrosis you go up, the mortality goes up. So at F1, so just started the journey, you are 1.5 times likely to die than your colleague who hasn't got that's liver. If you get to F2, let's say it really is almost 3.5. F3 here, it's 3. So you are 4 times more likely to die if you got F2, F3, because that's wrong. Well, you'd ask me, Farooq, you told us only cirrhotics die with fatty liver. So who are these people who've got 4 times more mortality than people next to them who are dying? Well, these are the ones dying of MIs. These are the ones dying of kidney failure. They're not necessarily dying of liver disease. And this is going back to the same thing that when you saw ultrasound scan evidence of fatty liver, you already have crippled arteries, you already have insulin resistance, you already have cholesterol. So when you do see fatty liver, I think it's thinking, sitting back and having a look. But why is it all relevant? Because you and I can regress it if we find it inside. So there's a method in madness. It isn't just because we want to see them aimlessly, don't want to do much about them. We do know that we can regress them. And a word of caution, fatty liver is the only disease apart from hepatitis B who can give you liver cancer without causing cirrhosis. Yeah, so just it's not that benign after all. We all know diabetes and fatty liver has got, but so risk factors. How? Look, I'm a family medicine guy, right? I've got 1,000 people to see that's got fat in their liver ultrasound. Do you really want to see all of them? Are you serious? No. So age, male, over the age of 40 is a risk factor. Male, gender, it is. If they've got type 2 diabetes, or even insulin, I don't know, Amber is not here. She really did one great job she did for us is included insulin resistance in our pathway. And that had made significant changes. So feel free to ask for insulin resistance, really. That would tell us. Of course, dyslipidemia as well as fibrosis we've just talked about. What is the natural? So I'm from Leicester, back home. And Leicester has pretty much got as mixed ethnicities as you would have in Dubai, really. So you've got Arab speaking, you've got subcontinent, and you've got English speaking. So we said, well, can we have a look at the natural history of these patients? So about 400 patients, like GPs referred to us for fatty liver. So well, let's have a look at them. What happens to them? 10% of them had cirrhosis at the time of presentation. And they were people who just have fatty liver, abnormal LFTs, may or may not be. At the time of presentation, 10%, 1 in 10 had cirrhosis. And this was really, really interesting. Look at this 18. 41 to 50 were the largest group of people, and that's what we have in UAE, right? We are a country of young people. And I'll show you, I've got a slide here that wouldn't put us, and that's another surprising thing. How many of you or I would have thought that BMI 26 to 30 would die of liver disease because of fatty liver? Yeah, we don't even have guidelines for these people. We said, no, you can carry on. Your BMI is below 30, get on with it. We won't offer you bariatrics, we won't offer you anything else. This is what you've got to do. But the largest group that have actually had cirrhosis in those was actually the one with 26 to 30 BMI, largely, of course, subcontinent and Arabic speaking. What I did, I went forward and I looked further, dissected the information, and look what we found. There is something in diabetics that we need to understand that I haven't got understood yet, I must admit. As it's red diabetes, you are non-diabetic amongst alcohol. And as the stage of fibrosis goes up, the level of disease progression is exponentially high. Exponential. And I must admit, I don't know why, but this is something that has led us to do this first ever study we did here at King's, where people, I think you've all been, Sophie, Hassan, Ali, all of you have been very kind and have participated in sending patients. 192 patients, your normal healthy patients who came for health checks. They have absolutely no problem with whether they have fatty liver, they have diabetes, or nothing at all. They just walked in to you guys, can we do executive, premium, whatever health checks they came for, right? So we invited them based on their ultrasound of fatty liver to have a consultation with ourselves, with a hepatologist, and do a fibroscan. Look what we found. So these are your normal healthy walking patients coming to King's Marina or King's Jamaica. Right? There's nothing extraordinary about them. Look, 1 in 5 have quite advanced liver disease. But they didn't even know they were just walking around in the clinics to you. Their girlfriends or their wives have pushed them, or the company offered them a free package, right? And I said, actually, that's what their presentations at this point. Can I actually find out how much of them have cirrhosis? 1 in 20. So you can actually look around you. We've more than 20 people in this room. How scary it is to find out that one of us may actually have cirrhosis in the liver already. We've already talked about the BMI. We already talked about the young age. So it's not that benign after all. It's just that we never learned that much about this. 17% of diabetes, Dr. Imran. Oh, Jawad is here. Jawad, what's your prevalence of diabetes in UAE in like a normal population? Right. Would you say 1 in 5 is diabetic? 1 in 5. So this is what our study have shown. But again, the similar findings. When I look just in diabetics, so 17% had diabetes, 1 in 5 about that. But 1 in 5 had advanced liver disease in normal population. But look at in diabetics, 1 in 3, confirming the same thing that Leicester data confirmed. They do have something. So maybe if your patients have insulin resistance or diabetes, he's the one that you need to refer very, very quickly. So amongst advanced liver disease, only 1 out of 4 had abnormal liver tests. Yeah. And that's your very pure UAE King's data that is. And these are not the individuals who actually haven't got liver disease. This is the individual who've got advanced liver disease. Only 1 out of 4 had that. So 3 we are missing really. If we are based our assessment purely on LFTs, 75% of the people we are not looking after, guys. And that's what.
Does that include TTT or gamma?
Oh, either way. So we look at ALT as well, gamma GT.
Has been abnormal.
Yeah.
Unlike transaminase.
Yes, it's not true. So here we do gamma GT as well as ALT as a final. So UAE nationals, we looked at 40% on presentation. Numbers are small, and I'm doing that study with MBRU and DHA now. We're purely focused on Emiratis, but even in our group, numbers were small, 40%. I don't know, maybe this is insulin resistance, maybe this is diabetes group. But this population certainly had. So yes, and this was the need of the moment, should you like, to have a fatty liver assessment, if not treatment program, in the region. So what predicts mortality? Because it's well and good, Farooq, you tell us, yes, it's serious, you scared us enough, but what does this mean? Am I really sending everybody to you, or does everyone have risk factors? What is the simplest way? You can't live past all of them, for goodness sake, right? So what predicts mortality? So nice study, about 600 patients who were followed up for about 12 years. And if I may convince you all, so the red line here is people who've got NASH, which is inflammation plus fibrosis. And you could also look at people who've got NASH, but no fibrosis. So what we now know is the fibrosis that defines your outcome, not necessarily NASH. 10 years ago, we were only focusing more on what is NASH. It's only swelling and inflammation of the liver on top of fat. That's it. There's nothing more than that. All right. And we thought the inflamed the liver is the abnormal the liver tests are, you are more likely to go get worse. Well, I'm afraid that's not true. Fibrosis we can do by doing a non-invasive fibroscan. We now have 2 machines at King's, and when we're hoping when we have the Diabetes Institute across the road, it may be really useful to have a fibroscan over there, because important is to do ultrasound. Why not? So we want to do, how long is it for me to take? 3 minutes. Very non-invasive, and it tells me exactly what stage you are, F1, F2, F3, or F4. Yeah, 3 minutes fibroscan sorts it all out. And we have now proven purely for this purpose, reassure your patients that they don't really have to worry about. There's no needles involved. We're not going to assess them dangerously or anything. It's very simple fibroscan. You can tell them it takes 3 to 4 minutes. It's entirely painless. It's just an ultrasound scan. And it gives you 2 readings. One, the amount of fat in the liver. Tell your patients at the beginning. It helps us a great deal. And the stage where you are. Okay. And they would be very willing to know. And as you can see in this slide, okay, people needing transplant, as we go on, you can see the fibrosis decides the outcome, transplant as well as mortality. So we now at least know there is not only it's much common in UAE, we now also know that we have a piece of equipment that allows us to assess these patients a lot easier and a lot earlier.
Dr. do we do the biopsy for these patients?
Only if I'm sending them for transplant.
And just like with the angio and the angiogram, that might be different. We do the CT angio for them to see that how much the MRI might be over such transfer test. But we do get a normal angiogram on these patients, like the calculations will check on the CT base. There is a variation. In this case, if we do the scan and shows us the fibrosis, that is certainly.
Yes, so certainly if it's advanced, then yes. There is, of course, a middle group, which is indeterminate, should you want to call it, but I don't think CT would be the best. So what me and Kes have been trying to do is to get an MRE here, the MRI scan. We've got the MR scanner, we just need the software, which is I think worth about $500,000. So of course we're going through the, but you're right, these patients would need further assessment. But who do I do liver biopsy? Who've got very high abnormal LFTs because they may be autoimmune. And I really don't want to transplant them thinking this was just fatty liver, because autoimmunes post-transplant need very different suppression. So how do we tackle this? This poor chap has nothing to do with this really. All he was the world's first leader who raised his voice to tackle obesity. That is all. So before you start, I don't like you mention. Anyway, all right. So why me? I'm sure you, all of you in your clinics get that question. Why me? I don't eat. I never eat. My wife's finished later than I am, but I don't. How come it's me? All right. My brother eats red meat all the time. He does. But he's not. I am. Right. So I thought it would be useful for all of us to just look back a little. Gut-brain regulation of the energy, again, it's very much decided by our homeostatic signals. When we feel hungry, it drives through the organs. Okay. There is certain part of this which is voluntarily controlled, but largely it is controlled by. So I normally tell my patient, your stomach and your brain, they're bedded now. They just talk to each other whole day long. And of course, as they happen in bedding, they get upset, in which case you may feel more hungry and therefore you eat more. It works exactly as that. But hands on the heart in the room, how many of us only eat when we're hungry? No, we eat even when we just eat. This is a peer pressure. We've gone out on a Friday night, and of course, we just had a bit of a cake and we had a bit of a drink and a Coke and a burger and what have you. Yes, we all do this. So this is a social pressure. More importantly, let me take you back to homeostasis. You and I are product of homeostasis. What does that mean? Don't get upset. I'm not really going through ethnicity. So 2 million years ago, only those individuals were able to survive who had the gene to last starvation. So by you and I sitting here, we can just assume that our genes are made up of fighting starvation. And this is important, guys. Just let me spend 2 seconds. Please don't blame your patients. They're not. When I do bariatrics, I tell them week 4 to week 7, you'll get plateau. You will not lose weight, don't get upset. Just carry on. Why? Because these are the genes that tap into locking mode. It takes them about 3 to 4 weeks to realize that, gosh, is he getting into starvation? He's going to die. I need to protect him. What does this mean? The basal metabolic rate goes down. So 100 calories that you consume is going to last there longer. So this is why you get plateau. All of us had experiences. When we start losing weight, it goes very well in the week 1, week 2. Week 3, we lose another 2, but then, oh, gosh, I'm not losing any more, am I? So we start eating back again. This is where we lose hope. So educating patients that it's the genetics. Don't fight nature. Just get on with it, and it will come a point when it will work for you. And very lastly, a very nice study. Look what they've done. They looked at around 16,000 to 15,000 people. So 10,000 were normal weight, 2,000 who were obese, and 1,600 were really slim. And they actually found those genes in these individuals that express the genetics for obesity and the locking rate. So it is genetics. It's not all patients' fault on the fact that he just was eating and therefore cannot lose weight. So just why me obese, and how much do I have to lose? Okay, very quickly. And if you want to treat blood pressure, then anywhere between 5 to 10% is acceptable, right? A lot of our patients want to know this. How much do I need to lose, baby? And thank you very much. You've told me now all these. If you have fatty liver without fibrosis, around 10%. So your 100 kilos patient can actually lose weight. If he gets to about 90 kilos, you would see, and the beauty of this is, liver is the first organ that would shed the weight off. So even if they lose 4 or 5 kilos, liver is the first organ that will let the weight off. The fat will melt from the liver first. And I think I normally use this to kind of encourage patients. If you've got NASH, then you're clearly talking about 15%, whereby if you have fibrosis, you're looking at 20%, 25%. And fibrosis is a group that we really need to worry about. And I really just wanted to show you, this is a very nice paper who looked at, so this is the MRI scan that me and Kendra are trying to get to into. And that's what it measures, the amount of fat. On the left-hand side is the same patient before he lost weight. And on the right-hand side is the same patient who lost 10 kilos. And look at the amount of fat from the liver that's melted away. But importantly, which is extremely relevant, when the liver fat goes from 17 to 3%, as is this gentleman, his beta cell function from the pancreas, it normalizes. All right, and his pancreatic morphology appears. It's not just the liver that improves. Going back to the same thing, the 25-year-old, when he had fat in the liver, he already had started the organs. So that's just worth bearing in mind. Very quickly, all of us think that we are very good solicitors and we can talk rubbish. It doesn't work. Look at the amount of 80 studies, 26,000 people. One thing that doesn't work is keep telling your patients, stop, lose weight, you're not losing, do right, do it again. It does not work. Advice has no role in making people live longer and healthier. So there has to be something else. 26,000, you can't really have any stronger studies than this. How much do I? So a lot of my patients ask this, and what I normally do, I'll tell them this. And for you who've got things on your desk, look at this now. Where was I let this slide later in the course? A coffee that all of us have about twice a day is 300 calories. Sorry. A slice of pizza, if you manage, is around 250. If you manage to have 2 because your friend was a bit more cheeky, about 500 calories. All right? Keep going. Important is how much do I exercise? So if you've had a coffee, you need to run half an hour to be able to burn that calorie. That's unachievable. Can you now see how the exercise alone can never, ever do this? This is a waste of time. We keep telling you off for nothing. And I mean, because how many times have I not got that and that looks so good when it goes inside the thing? I handle the heart. I mean, imagine the time of hours. I don't know about you, I don't know if it's in the room or not. I will be sad if I keep running this many hours to try and keep myself fit today. What time will I work? Yeah, nobody can do this, and that's important. That's what we need to tell patients. This is where the diet comes in. This is where what you need to do to be able to lose weight. Yeah. So, very gentle advice about it. And I normally do combine the two about the exercise, and I think it's really, really relevant. I tell them 3 times a week. You don't have to do it every day. 30 minutes a day, jog, cycling, swimming, right? Aerobics. There's no need for you to push it, and combine 10 minutes with loose training exercises like weight training, whichever you want to do, 10 to 12 repetitions for 10 minutes. So 40 to 45 minutes, combining aerobics with this, it works. Studies proven it, good for NAFLD. Okay, what about diet? Is there a balanced diet? All right, well, let's have a look. Well, what are the factors? Snacking, right? Excess, how many of us running late in the clinic, and we found it a lot easier to grab our hands to something which is whatever's chocolate. Snacking is, I think, is a big killer. If you really, really girls in the rooms in particular, put peanuts in the bath. So you grab a bowl of not chocolates, not sweets, not Mars bars, but instead, if you really, really do want it, a very small change in life bring a huge difference. So what is the ideal diet? Calorie restriction, yes. Set meal times, guys. Encourage your patients to do that. I don't do breakfast. I'm busy, doc, so I just go to work, and then when I come home, I have to meal. But wrong time. Your metabolic rate is going to go down at night time. So why are you eating 800 calories at night? It's just wrong. They're not going to get utilized. So that's why it's important to tell them. Intermittent fasting, enough. Twice a week, more than enough. They don't have to do it every day. Proven, Mediterranean diet is more helpful for fatty liver. So if your patients have fatty liver, I think it's not, and research proven, not that I've taken commission from any of these. More important, if you have fibrosis or NASH, then weight loss is important. Yes, so just bearing that in mind. And what's the effect of exercise? Kate Holdsworth from the Newcastle group really combined this all for us, different meta-analysis. And you can see, and I normally tell them, it doesn't really matter, jog, crawl, run, whatever you do, everything works. Aerobic, resistance, HIIT, intense, combined, whatever you want to do, it works. As long as you do it. Yeah, and that's a very, very important idea of it. Is timing of weight loss relevant? The answer is yes. And I think that study has really educated us significantly. Initial weight loss determines how long are we going to lose. So first 2 months are very important. If your patients haven't lost over 4% in the first, you've got to change something, please. It's not going to work. Yeah, so just bear that in mind. When you put your patient on weight loss journey, if it isn't achieving 5%, whatever they're doing over the next 2 months, that's a predictor of poor outcome. They're not going to do well. They need adjunct. Okay. And what's the role of pharmacotherapy? I wouldn't bore you all because you're not all hepatologists. Vitamin E is the only thing that I use. Pioglitazone's not that great. And we were very hopeful when the landscape of NASH came. How can I treat it medically? And there were really four. One was obeticholic acid. The second was LOXL2 inhibitors. Then we have elafibranor as well as GLP-1. I think if anything that's worth talking about is GLP-1s because they had shown some promising results in this group. I wouldn't bore you with all these studies because I don't think it's relevant. The bottom line is really nothing works when your NASH or your fibrosis kicks in these groups, and drugs after drugs after drugs we've tried and it doesn't work. GLP-1s showed some promising results. So Matt from Birmingham group did that very first lean study, used lower doses, but he's still shown that at least if you couldn't stop the fibrosis, you have slows the progression of NASH. Okay, this concept was taken up by Semaglutide, which sounds very promising. And the step 1 study was really positive, I must admit. So, I mean, 14% weight loss as compared to 2.4 in this group, really nice. Okay, which then led it to step 4, but that was really disappointing. So as the need for the weight loss goes up, you can actually see that the insulin resistance, the weight loss, that's really not there. And there's a thought that was down to patients' own compliance, because of course they start to get GI side effects. So that's where, for us to be able to achieve 25% of the total body weight loss to reverse their fibrosis, GLP-1s haven't really convincingly shown much of the evidence. So Phil Newsom, my colleague in Birmingham, he's done the first liver biopsy study on semaglutide. He was hoping that it would work. We were all, in fact, but sadly, no improvement in fibrosis. So once the fibrosis kicked in, then your GLP-1s don't work either. Well, okay, well, what does work? Surprise, surprise. And that moves us to endobariatrics. And does that work? It does, because we've now managed NICE. If we've convinced NICE, take it from me, folks. Because in UK, you cannot convince NICE to spend money on. So I started fatty liver bariatrics program in Leicester, and we were actually doing balloons on NHS as well as sleeves. So it works, we know that. And I'll show you the evidence. So my partner in crime, Jude Owen, guys in St. Thomas's, did that first ever study on balloon on NAFLD patients. And look what he found. This is, by the way, 1 year balloon. I know we have 4 months, we have 3 months. We here at King's, I know it's very commercial, they can have 3 or 4 months balloon, but actually tell your patient it doesn't really matter. 4 months is not enough. We did that study with 6 months balloon, and 40% of our patients, we had to put another 6 months for them to be able to not only achieve but maintain weight loss. And this is the first time we actually seen about 30% reduction in their insulin resistance. That takes us to the sleeve. I'm not going to bore you with this, but that's how it works. We really, here at King's, particularly when we do sleeve, we need the top bit on touch, and that serves as a camel effect. So your patient doesn't get hungry straight away because some of the food gets stored there. I wouldn't show you the video, you won't be interested in this really. But that's basically on the left is my patient with fatty liver. That's the stomach where I did it. And on the right, that's the liver. So you can see a very nice tunnel, and that's your sleeve. Does it work really, or is it just the fashion? Well, actually, no. So Mayo Clinic, very decently have proven 49% of our patients at 12 months have actually the excess body weight loss was over 25%. So we can't really. More importantly, if I may convince you, look at the BMI. As the BMI goes up, even the sleeve, if you like, performance outcome, it goes down. Your weight loss goes down as your BMI goes up. So maybe sleeve is only for certain individuals, not for everyone. But the key is to pick up early so we can. Does sleeve really work in fatty liver? The answer is yes. And this study has really, really proven significant effects. So sleeve patients, endoscopic sleeve, we did it for 2 years, follow them up, 118 patients, pure with NAFLD, they've done the fibrosis score, they all have high insulin resistance. And look at the amount of weight loss they have. But what I'm not really interested in, anything can help you lose weight. What I'm interested in is insulin resistance, because I've told you that's what's driving the whole thing when you have fat in the liver and the fibrosis. So this study was really convincingly, it was only 2 years old. So as the world has started to learn that the treatment of fatty liver is weight loss. And when we talk about weight loss, we just have to work out what stage fibrosis you're at, because that will decide how much you need to lose. And that will plug you in as to whether surgery versus surgery works, guys. There is absolutely no doubt. So there is, if one thing that had altered the outcomes of my patients with liver disease is really a nicely done surgery at the right time and the proper way. However, just a caveat, don't even, this is the in-hospital mortality for patients when they have this study. And look at the stage of the disease goes up, the mortality, not surprisingly, yes, I'm even surprised that they had bariatrics on decompensated patients. But even then, so again, the key is you refer them early, you assess them. And that's why we're the only center that's included fatty liver in our bariatrics program, because we know that if there's a treatment that works with these patients, is actually weight loss. No other medication does. And weight loss, proper weight loss, depending on what stage of liver disease act. You can try medications, you can try endoscopic, or you can try surgical treatments. So the whole idea of today's talk would be known as the lifestyle habit. Try and assess them. Fatty liver is not benign. Having normal LFTs means nothing in these patients. And we now have much more non-invasive ways where we could assess these patients, and we can tell them whether they do it or not. That's entirely up to them. And our results have shown that these are normal, healthy walking patients to your health clinics. And look what we find. I'll take questions now.
Thank you very much for the talk. A lot of the questions. Because we follow the people and the doctors, source their time balance the page. You talk to the patient and really help them see. Secondly, these days, fibrosis is one of the key factors. Even if you care about family medicine in terms of having a fibrosis scan, how does that protocol usually do first?
Yeah.
And who we can just put the weight loss.
In fact, we did, the other day we were discussing this. That's why we, in the diabetes issue, I think to start with, one of us will go and do clinics when it's all up and running, because this is really a very large cohort that we need to focus on to begin with. Resources are, of course, so the equipment is around, $500,000? It's around 600. And then we are, no, the fibro scanner. It's about 500,000. So our intention really is that in time to come, when the whole idea of this education was that actually we might have a fibroscan in every clinic. I mean, it's like no transplant, we'll train you. That's absolutely no, there's only so many fibroscans that we can say, Regina, or we can do, of course. By all means, there's nothing too technical about this. If you want to do it, that's fine. What was the other question?
So, there's no very more pattern or more listing. I mean,
Risk factor? Who haven't got the risk factors?
Well, we listed like 5 risk factors.
Yeah.
You can also for every male patient who create more pattern than their person.
No. So 40 and plus. So 40 and plus male, if they have at least 2 risk factors. So if they're diabetic and or they've got cholesterol. Yeah? No, not really. Because then the chances are really, really low. What if that is what you would do, you would monitor, right? You would monitor the weight. But don't discharge them. So it's not that benign. See them 3 months, whichever way you want to follow them up, but follow them up. Yes, you're right. So normal LFTs, less than 14, male, you've got no other risk factors. If they're high BMI, you would watch them.
So I missed out on my health. I did a very healthy life, very fit. I just felt like I had a strong liver. So
Yeah.
so I'm going to come and see. But patients get alarmed because they go to large liver. So my question is, what does it have to make it come? So
That's fatty liver. If you go back to that picture, you would see the normal liver, and so fatty liver is a big liver, and that's the fatty liver. What you need to worry about if they have splenomegaly, that tells you something that may have been advanced liver disease or fibrosis, because splenic vein drains into the liver towards the vein.
So if we got maybe agree on because you get sometimes you water just based on the negative.
No, again, it's a risk factor. Again, as we took please. I know. There is actually. There is. Yeah. So one of the risk factors for acute vascular pregnancy is pre-existing vascular. You're going to have to deliver the person. Oh, no, I meant baby. You're going to have to deliver it. You have to do it, please.
So this is from a pediatrician perspective.
Yes, please.
So of course, we all guys can see children who are obese.
Hmm.
And if you see them having 1% fatty liver, please don't think it's only because of the weight. For us, it's a diagnosis of exclusion. And multiple other reasons, kids do have fatty liver and we do need to work on it. So it's not equivalent to the 40 plus of diabetes factors with fatty liver. From a pediatrician perspective, it's a completely different model.
So you need to think of this. Honestly, do a screening on this. If this is something which the world has not understood well, we will solve the problem.
But really purely on the metabolic,
Can this publish under 12? Has that been validated? Yeah.
All the fibers kind of plus and minus, kind of high cost. Fibers can move to okay. We must not forget and actually every single ultrasound machine, GE, Archie, Philips, they all have built-in elastographic software. And elastography is not used just for liver, it's used for spleen, used for breast lesions, The only problem my fibers can always go in international discussions and meetings because they have no data. And you can't compare the elastography on one side to the other. Do other things. The advantage that they are making about it, if you got another year, this is important. They also reporting only ultrasound strategy, but when you diagnose strategy, you must develop a very careful. There is a lot of financial issues. We don't start reporting 5% how we do.
That slide I never thought about.
Ultrasound scans will now start reporting liver biopsy. Once they get the value, it's fine. You put in a different path and how you can send them in. And now, MRI. One more thing happens is that I get a lot of excited focus on that. I did that. I was just not okay. And so fibroscan values are all over the place. I got a guy, fibroscan was under hospital, he was 14 kilopascal. He did not look like 14 kilopascal at any standard. Out of my own intelligence, commonly fibroscan, it was 6 kilopascal. So the way fibroscan is also different. You lose fat, your enzymes come down, so fibroscan value is changed. The fibrosis is not changing, the liver stiffness is changing. And liver stiffness can be anything. So your enzymes are like at least more than 150, stiffness will be high. Too much fat makes the liver stiff. That's just about where liver is stiff. Any bioinformatics, you look like cirrhotics, liver is so stiff. So understand, it's only liver stiffness not high. So here MRI scopes. MRI, it's right there we have MRI gastroplasty. Put a small kind of a 20 hertz, 20 vibration per second, then why the liver shakes, and the shaking of the liver is captured by MRI. If the liver is firm or hard, the whole thing shakes like one unit. And the liver is soft, and then the waves get transferred to the liver. I hope you can understand. So the very the most studies now on fibrosis reversal of fibrosis progression use MR elastomer, not. So I have a lot of observation. It's a good screening.
It's a screening tool. It's a screening tool. And that's why I think we should actually have a fibroscan in every clinic.
And I just add a point. So thank you very much. Amazing talk and it's becoming quite nice that you're getting non-invasive intervention like liver fibrosis is not diagnosed it used to be. So people are also asking for non-invasive kind of treatment options. And I know you mentioned for hepatology may not have a huge role, but it would have been nice to mention essence trial on semaglutide, which is recruiting patients just to look at NASH. Although the recruitment has not been completed, but there are some issues functioning. And again, the incretins, which is the combined GLP and GIP agonist therapy, like tirzepatide, right? So the findings on weight loss are actually quite mind-blowing. Perhaps not replacing the but as close to as dietary, you get non-invasive. So people are asking for non-invasive therapies. So there are very good.
The options are very good, but it's the fibrosis that we are bothered with. And what the studies haven't shown as yet, that once the fibrosis kicks in, then GLP-1s haven't reversed that. So they've done the weight loss, they've done the fat content over time.
Alpha delta. So PPR axis has got a big role in this state of blood story. So sourdough is an Indian drug that was made for diabetes, never really works for diabetes, but works very well for diabetic hypertriglyceridemia. 60% reduction in triglycerides. This drug is in and they have got a lot of trials, multi-center trial. Now, recently, last summer, they published it in recently, so like dominating early reversal, they have now found that also in they have 500 each of them have 6 months and 2 years. So of course that's very time. But there is not a voice in the world. Lots of things, not millions but billions of dollars. I'm sure we can and not GDP money, even you know how I got a patient yesterday, he has to donate his liver to his father, and it's given 3 months to lose weight. He's losing weight, he's because parameters are managed on SGLT. SGLT also helps lose.
Wait, yes.
Only drug which will make you lose glucose.
Yes, it is. You done,
I'm
right?
ready for final scan next week, yeah?
I'm sure it's not covered in the insurance, so.
Other things covered. It's covered. Mostly.
This is the beginning of the policy.
Yes, I think it's 300. It can be. I can do. What for you it's do? So, guys at the JMC and MMC, I hope you found it useful. You all have my email. If any questions, by all means, just send us the email. And thanks for joining. It was really useful to have all of you. Bye-bye.
Thank you, Doctor.